I'm Jennifer Mulholland. I'm the prostate navigator at Christ Hospital. It's a new position that they've created, and I'm currently in the development of the program still. But one of the things that I do is I am running the second opinion clinic. So we offer prostate patients that have just been diagnosed with cancer or having a reoccurrence of cancer a second opinion that they can have an appointment with a urologist, a medical radiation, or a medical oncologist, and a radiation oncologist, all in the same appointment. So that's been we've been getting pretty busy with that. And it's a really patient-centered care. It's a really unique opportunity. So that's practice for them. That was second opinion with all three. And then as far as the navigation system goes, I'm helping the patient navigate through making sure they're just going from the urologist, the medical oncologist, the radiation oncologist, make sure that all of them are talking together and the care is seamless. So there's not a delay in getting your PSA checked or your follow-up appointments, making sure the appropriate scans are ordered and things like that. So that program's still being developed now.
Excellent. Hey, Sean. Hopefully this isn't too loud. I talk generally pretty loud, so I kind of have to move it further and further away.
Good.
So
Very good.
if I hand it to one of you guys to hold it for me, don't feel bad. So, well, again, thanks, Jen. I appreciate it. As Jen said, the Prostate Cancer Collaborative, the Second Opinion Clinic, is a new thing that we have. It's not necessarily a new thing that we have at Christ Hospital, but it's something that we've been working on to really perfect and make very meaningful for our patients. Having an oncologist, meaning a medical oncologist, a urologic oncologist in a sense, as well as a radiation oncologist is very important because a lot of these cancer cases, as you all know in this room, it's a very collaborative effort. Whether you're getting radiation or you're not getting radiation, whether you're getting surgery or you're not getting surgery, oftentimes you're going to have all three doctors in play at some point in the scheme of prostate cancer. Whether it's you just got diagnosed, you have Gleason 6, 1 out of 12, you're going to keep an eye on it, all the way to someone who's had their prostate out, it recurred, they got radiation, the PSA continues to rise, now you're starting these medications like Xtandi, some of these more advanced prostate cancer drugs, and ultimately seeking the care of an medical oncologist. So, whether you're getting surgery or radiation, or any of the treatment options, cryotherapy, etc., we try to make it a very collaborative effort because at some point we're all going to be involved. And the other things that we are all able to, the three of us are able to really talk to one another, more in a collaborative effort, right? It's not, I'm the surgeon, I'm going to take your prostate out, I don't care what anyone else thinks. It's all about what's best for you guys and what the best treatment option is for each individual, because it really is different for everybody. Okay, so please feel free to
tell us your background.
Yes, absolutely.
So
again, my name is Anish Shah. I actually grew up in a small town called Athens, Georgia. I don't know if any of you are familiar with it, home of the Bulldogs. So I grew up in a small town of about 150,000 people. 50,000 were college students. So during summertime, it became a pretty small town. I got accepted into a 7-year medical program out of high school at the University of Alabama at Birmingham. So I went to the school, UAB, for undergrad, and then I matriculated there after undergrad for my 4 years of medical school. So I got interestingly, a philosophy degree. What am I going to do with that? And then I was there for 3 years, and I said, wait, I'm about to go to medical school. I should probably do something else. So then I did a degree in biology, and I got a minor in chemistry. I graduated with honors there, applied to Cincinnati, UC, where I completed my 5-year residency program, 1 year in general surgery and 4 years of urology. Finished that up 2014, and then joined a practice down in Atlanta, Georgia, closer to home, closer to my side of the family's home, where I was in practice at a health system, much like Christ Hospital, called WellStar Health System in Marietta, So I'm not sure if any of y'all are familiar with it. It's just north of Atlanta, about 10-15 minutes. And there, I took a keen interest in prostate cancer, really all genitourinary cancers, bladder, kidney, prostate. Started something very similar to what we have here tonight. We started an advanced prostate cancer clinic, which Jen will talk about maybe in a little bit, or I can talk about it. I also, was one of the robotic surgeons in my practice, which was always a nice thing because we had the prostate cancer collaborative clinic down there as well, and it was very worthwhile for our patients. So I was in practice there for about 4 years and moved back up to Cincinnati. It was kind of a mutual decision between me and my wife, who's a Westchester native. They always say you can take the girl out of Cincinnati, but at some point she's going to be back. So we were really glad to move back up here. And currently we live in the Mount Lookout area, pretty close to all the locations that Christ Hospital has, which is pretty nice. So a little bit about me, but in terms of urology, just in general, I have a focus on oncology that I particularly enjoy caring for those patients, and you guys, as well as general urology, weak stream, ED stuff, kidney stones, et cetera, et cetera. So I know this forum is more for prostate cancer itself, but of course we know that as men get older, some of these other things will crop up. So if you guys need any of those things or have any questions about that, by all means, please let me know. So I know we probably have a mixed bag of folks in terms of different parts of the prostate cancer sort of spectrum. And from what I've heard from Dr. Shank and Dr. Geyer, it's a knowledgeable bunch. So that's wonderful, and I always find that it's a lot more of a worthwhile experience when you kind of house your health in a sense, where you're as knowledgeable as you are, and then we supplement that knowledge as well and try to make treatment planning decisions and future care as easy as possible. I consider myself more of a facilitator as opposed to just a surgeon or an oncologist or whatever, mainly a facilitator, because oftentimes when you're coming up with a treatment plan, it's really about the risks and benefits and of course cancer outcomes. So that's what we do to try to help.
One of our guys is going over to Christ for trying to stay dry. He's been over there and they've been doing, what kind of injections was he getting? Somebody help me with this.
Was he getting like a collagen or macroplastic injection or something like that?
Injections, I believe.
Yeah.
And he was getting close to success with that. Maybe you can discuss that. And do you do any slings? We hear about slings all the time.
Yeah,
I've never had anybody in here that's had one, I don't think.
Yeah, so slings, slings can be very good for low pad per day leakage. So we know that the two side effects of any prostate cancer treatment, the two main ones are leakage of urine and ED. Okay, so we would hope that by 1 year, for instance, after a prostatectomy, that since the national sort of average of continence is about 95%, usually by 1 year, less than 5% of patients have significant incontinence. Significant incontinence is not you lift something heavy or you sneeze real hard and you leak a few drops. Significant incontinence is I stand up and I walk and I'm just leaking urine. If that's the case, the sling procedure is an option, but really if you have that profound amount of leakage, we usually offer an AMS product called the artificial urinary sphincter. I'm not sure if you all have heard about that at all, because the outcome data is much better for that. The other thing is, when you talk about any mesh, whether you've had a hernia repair, whether it's in your belly button, down to your groin, for females, if they've had pelvic floor mesh, there's always that risk of infection, erosion, And last but not least, it's a very porous sort of thing. So tissue is going to grow into it. The idea behind mesh is that the body incorporates that into its normal fabric. So the problem sometimes with that is if it doesn't work or it tightens you up too much, now what do you do? Okay. So I personally, I have not used the mesh too much. I used to for the first year in my practice, but I started doing a lot of, well, it's kind of interesting. I started off doing a lot of those artificial urinary sphincters, and then as I started doing all the prostatectomies, my goal is to try to reduce the amount of leakage so that I would never have to do the operation again. So luckily, I haven't had to do very many of those operations for that reason. So, but just to kind of give you an overview of the sphincter itself, it's a two-piece system. So think about like a hydraulic pump. You push one thing, it siphons fluid from one thing and pushes it into the other, and then it goes back. So you all may have heard of the penile implant that we use for erectile dysfunction, where you got a reservoir behind your pubic bone, the tubing's attached to a pump in the scrotum, and then that's attached to two cylinders in the penis that go up as you pump. So the idea is you're pumping and it's siphoning out of the reservoir through that pump into the cylinders and going up. It's a generally off, you turn it on sort of thing. You push it to activate it. The sphincter, in a sense, is the opposite. It's always activated, you push it to deactivate it. So the idea there is you've got your reservoir, which is obviously a much smaller reservoir because you don't need as much around the urethra. So you have your reservoir, that connects to a little pump in the scrotum, which is about yay big. And the idea there is when you pump that, or you squeeze it once, it relaxes a cuff around your urethra. So ordinarily, when you put that cuff around the urethra, you're keeping it nice and tight so you can urinate. When you push that button, it relaxes that cuff for a period of 1 minute, and then it closes back down. So during that 1 minute, when you push the button, it opens, you urinate. Once you're done urinating, it closes up on its own, which is a very, very kind of, it's an interesting sort of thing. So
does the air expand it, or does the air contract?
It's not air, it's water, and it's saline.
But does it contract it or expand it?
It's basically siphoning the fluid out of the cuff back into the reservoir. So normally your reservoir is empty in that situation. When you push the button, it's following a negative pressure system. So water's or saline is going to follow the path of least resistance. So it's going to go down and back up, and then once the pressure is regulated again, it's going to go back in. It's going to form it again. So it is a same-day procedure. Normally we keep a catheter in you overnight, keep you overnight for just observation, cover you with antibiotics, send you home with about a week of antibiotics. And what we do after we do that procedure initially is when we put this cuff in and we put everything in there, we don't want you to use it for about a month. We lock it open and we let you leak just like you were before until everything sort of heals up and scars in place in a sense, and that's when we activate it. Okay? Because we don't, one of the most devastating risks of any sort of prosthetic, whether it's a penile prosthetic, a knee replacement, a hip replacement, an artificial sphincter, is infection, right? So we want to eliminate, or at least limit as much as possible the risk of infection. So our way of doing that is let the incision heal completely. Don't touch it, don't play with it, don't mess with it. Apart from once a day, just kind of making sure that that pump is in the lowest part of the scrotum, we say don't really do very much to it. So flash forward about a month, once everything's nice and healed up, the skin incision's healed, the pump's in the right place, the reservoir's in the place, the cuff has kind of allowed normal tissue to kind of form around it, that's when we teach you how to activate it. So normally we've locked it open, so all the fluid's in the reservoir that first time, and then a month down the line, we press it real hard, it activates it, all the fluid goes in there, and it stays there. And so then when you feel 3 or 4 hours later, I gotta use the restroom. You go to the restroom, you gently press once real deep on that pump. This will relax, you urinate, closes right back up. And you can go about your business.
Is the pump outside or inside?
Inside.
Inside.
Yeah. The pump is, it's a small little, it almost feels like, if you think of like chapstick or something, like those small chapsticks, it's about half the size of that and a flat version of it. So it almost looks, I'm trying to think of something, let me see if I don't know if I think I dropped this stuff off at the hospital in terms of what it looks like. Sometimes I keep models here with me.
Is it inside your body, doctor?
It's all inside your body.
Yeah.
100% inside your body. So there's nothing external. I could have a sphincter, right now, and you never know.
I'm curious, what, during those, you said approximately 30 days that you're letting, how do you urinate then, and even after?
Just like the way you were before.
So you use your Kegel muscles and?
Yes, so normally these procedures are for stress incontinence. That's the cough, sneeze, laugh type of leakage that's due to the sphincter muscle that sits right below the bladder, due to it being incompetent, or it's not able to really hold the urine. What I usually talk to patients about in the office when I talk about risk of leakage is I always tell patients that after surgery, you will have leakage on the front end. You will. 100% of patients do. As you work on those exercises, what you're doing is you're strengthening that hammock of muscles down there so that you can strengthen a muscle called the urethralis and the external sphincter muscle that keeps the urine in. Okay? So think about, if you think about why women generally have a higher risk of stress incontinence, that cough, sneeze, laugh type of leakage, more so than men, is because the prostate is usually a resistant organ. It offers some resistance to the flow of urine, which is why as we men all get older, we have a weaker stream, we dribble, we wake up at night, it starts, it stops. It's because the prostate itself is an organ that causes some resistance. I talk about the prostate when I counsel patients in the office. Think about a donut. As you get older, that donut gets thicker and longer, and the donut hole gets narrower. So now you're trying to get Niagara Falls to a straw. Makes it a lot more difficult, right? So the fact that we men have prostates means that there's some resistance. Now, once you had a prostatectomy, you've removed that organ. Now you just have a bladder, urethra with a little sphincter in it. Something very similar to how women's anatomy is. They have a bladder, they have the urethra, and they have a sphincter. They don't have any prostate or anything like that. So just like women have to work on their pelvic floor therapy exercises or Kegels exercises, men after surgery do have to work on those. And I usually counsel not after the surgery. I start that counseling well before the surgery decision has even been made. Go ahead and start doing sets of these exercises, sets of 10, 3 times a day. Because if you can localize those right muscles before surgery is even done, then when surgery is done, you're already ahead of the curve and you can start working on those exercises much easier and more readily to help maximize that tone. So the other way I sort of talk to patients about this is, it's a muscle just like any other muscle. If you don't exercise your arms, you don't exercise your legs, you're going to have weakness. You're not going to have that strength, you're not going to have that tone. You do a few curls a day, you do a few squats a day, you're strengthening those muscles. You have to do the same thing for your pelvic floor muscles. But there's a fine line between doing enough to keep a tone and overdoing it. So if I did 5 curls, I'm going to have nice toned muscles. If I do 150, my arm's going to fall off. And that's only going to make the leakage worse. So we always say do it to where you're feeling like you're working those muscles, but don't overdo it. Don't fatigue those muscles when you're doing those Kegels exercises.
This may seem kind of weird. I ride a bicycle and enjoy doing it. That's how I get a lot of my activity. Can you ride a bicycle with this?
With the sphincter?
Yeah.
You can. We just say that during that first month, not to do it.
Okay. And then
Because the incision site is
I'm
down
also
there underneath the scrotum.
I'm also in favor of keeping things simple, and I don't know, is it cosmetic just for appearance sake that you put it inside, or could you have a cuff on the outside?
They do make things called Cunningham Clamps. I don't know if any of you are familiar with Cunningham Clamps. It's basically a foam it's basically like, almost like a foam nutcracker in a sense. I mean, you've got foam on the bottom, foam on the top, and it just clips into place. So the idea there is you clip the head of the penis to keep the urine from flowing out, but it's not, number one, it's cumbersome, it's uncomfortable oftentimes for long periods of time, and it's not really, it's more reactive than proactive, right? You're not really doing anything to the part that's potentially injured or not strengthened. You're just saying, okay, well, I'm leaking, but I'm just going to press down on it to keep it from leaking out. The thing is that the second you take that little clamp off, urine starts flowing.
Does the penis have another sphincter in it?
It does. It has the internal urethral sphincter, so there's two sphincters. One is the bladder neck musculature, so it's where your bladder goes down and forms, kind of merges with the prostate.
Yeah.
And the second and stronger one is the external urethral sphincter. So when you had a prostatectomy or you've had radiation, whatever it may be, oftentimes that internal sphincter, definitely with surgery, that internal sphincter is damaged because you have to separate the bladder from the prostate, remove the prostate, and then just sew the two ends back together. Okay, so the mechanism of that is kind of lost in a sense. Then of course with radiation, you're affecting that as well. But it's a coordinated effort between not only the sphincter muscle, but all of the pelvic floor muscles that keep everything together. If you look online at any, if you Google search pelvic floor muscles and you go to Google Images, you're going to see a lot of pictures of a pelvis with a lot of muscles that look like this. It's basically a hammock that has a muscle called the uretralis, which is in the front, and the rectalis, which is in the back. Uretralis is what wraps around the urethra to combine with those sphincter muscles. Rectalis does the same for the rectum muscles, which is why whenever I talk to patients about Kegel exercises, I tell them it's like two things. And neither of them are very, not good explanations, but they drive home the point. One way of doing those exercises is if you're just about to pee and you're trying to just pinch it off. That means you're working on that sphincter muscle, okay? So when patients first start to learn that after their prostatectomy, sometimes they'll learn how to do those Kegel exercises, but they'll leak a little bit. The goal is, that's fine, leaking a little bit, trying to shut it off. The second is if you're trying to hold yourself from passing gas. Where you're kind of fidgeting a little bit and kind of tensing that pelvic floor musculature to keep from passing gas, that's what that muscle is. So it's all a generalized kind of hammock of muscles that's laying just underneath the skin underneath. So it's a little bit deep, but very deep down in the pelvis.
I'm also curious, my general practitioner, he's a good doctor and I like him, but he generally doesn't know how much anything costs.
Mm-hmm.
And I'm curious, are you different? Do you happen to know how much this costs? Is it covered by Medicare, insurance, or out of pocket?
I do not know for sure. One of the things that makes us a little bit working for the hospital is that, it doesn't directly impact me. So I don't really know the cost of it. I believe Medicare does pay for it with the right code, the right ICD-10 code, or the right diagnosis.
Make sure you're actually checked into the hospital.
Exactly. So, and sometimes they'll say, hey, we'll pay for it, but he has to be out of the hospital in 23 hours. He has to be there at least 24 hours. And oftentimes it's kind of like if anyone's ever had their prostate removed, sometimes Medicare will say, there has to be an order that says this is inpatient, not just 23-hour observation. So that's one thing. The other thing is that if we say, incontinence after radical prostatectomy, or we say stress urinary incontinence in a male, those are ICD-10 codes that would cover the procedure, provided there's nothing else. Still has to go through a prior authorization process and all that. I've never had a big issue with regards to getting it covered. I haven't. And the thing is if they're going to cover stuff like penile implants, for instance, which some would say is cosmetic, then generally speaking, they'll cover the sphincter as well. I cannot speak on behalf of all insurances, commercial insurances, et cetera. There's so many plans now that it's a little bit difficult to tell, but well before any surgery, was done, our offices are working, behind the scenes, getting the prior authorizations. Actually, John Strong is one of the AMS reps. I've known him since I started residency. So I have him on speed dial in a sense, and I just shoot him a text and say, hey, I'm planning on this sphincter, keep this name out, just remember this name because I'm trying to get it on in a couple of weeks and I want to expedite this prior authorization process. So there's a couple forms we have to fill out that we send over to the insurance company and AMS, and once we get that information, they end up generally clearing it. But again, I don't want to tell you that every patient's cleared or not. Now, out of pocket, I wouldn't even know where to begin telling you how much that
Well,
would
if it's
cost.
covered by Medicare, they already have those rules in place.
Right. So I don't want to make up a number and tell you, but it probably has, at least a 1 and 4 zeros after it, I would guess. So I don't know for sure, but they can put whatever number on paper, but of course it's different how much it would cost out of pocket versus what is on paper, what they would bill. Yeah.
This time, Christ Hospital docs were here, we were talking about CyberKnife. And they said, well, we don't know about 5 days, and we don't know if we need 42 treatments, but we're somewhere between 10 and 18.
Yeah.
What are the radiologists recommending these days for that kind of treatment?
Yeah, so I've never actually administered CyberKnife. The data behind it is that, and same with proton beam, CyberKnife, external beam radiation, IMRT, all these different therapies. The idea behind things like CyberKnife and proton beam therapy are that you can get more focal sort of radiation therapy to reduce the risk of scatter radiation that can cause proctitis and blood in the urine and a lot of urinary symptoms and diverticulosis and some of these other things. CyberKnife, the data behind it is that it's probably no worse than conventional external beam radiation that we do. But we don't have that 15, 20-year data like we have on IMRT therapies, etc. Same with proton beam.
Well,
It's the same thing.
Are you in fact doing 10 treatments or 14 treatments versus 42 or not?
I don't have enough information to be able to say that. That's why I kind of wish Dr. Geyer was here or something so he could answer some of those.
Yeah.
I don't believe he's doing CyberKnife. I don't think he is doing
I'm not
CyberKnife.
familiar with that.
I think usually if we're doing CyberKnife therapy, patients are going over to UC and working with Dr. Barrett over at UC, if I'm not mistaken. I think he may be doing some CyberKnife and probably proton beam because they spent about $250 million on it when I was a resident. So they dug up every road in town. So I wish I had a better answer from you.
So do you have the CyberKnife for Christ, or do you have to go somewhere to get it?
I think you have to go somewhere to get it for CyberKnife for the prostate.
What do you have mechanically for radiation at Christ? I'm not familiar with.
We have IMRT, which is intensity-modulated radiation.
Right.
And then there's this idea of like stereotactic radiation, but that's something that usually comes, after. For instance, if if you need to radiate a prostate that's high-risk prostate cancer, and you remove the prostate, you're doing very high dose, but just 5 or 10 treatments. We don't offer that at Christ Hospital. We offer conventional IMRT. So the old external beam radiation used to be, you just kind of zap where the prostate is, but there's going to be some scatter. Intensity modulated means that you're getting a very finite area of where you're actually doing the radiation. So you're getting the meat of the prostate, but you're watching the edges. And the way that we watch the edges is we do what's called fiducial marker placement, okay? So that's a procedure much like a prostate biopsy, except instead of taking biopsies transrectally, we put the ultrasound in the rectum, but through that area called the perineum, which is just under the scrotum, just above the anus, we're actually putting in 3, in a sense, seeds, but they're basically 3 monitoring instruments in a sense, okay? So they're either gold or something called Calypso. The idea behind these is so that when we put these 3 seeds in the prostate, when Dr. Geyer or either of the Dr. Geyers, Natalie or Rod, when they do their radiation, they know exactly where those seeds are, where exactly the prostate is, so that they can deliver the appropriate dose to those particular areas of the prostate.
Do you have a parametric imaging at all?
Like multi-parametric MRI?
Yeah.
We do. Actually, for all of UC, which it's kind of interesting, they're the academic center, but we have the 3 Tesla MRI.
You do?
So we have that MRI. So anytime we do, we refer a patient over to MRI fusion biopsies or something like that. We're going to be getting that hopefully in the next year or so. But right now we're doing the MRIs, and then if it is a biopsy based on an abnormal area on the MRI, and they're getting an MRI fusion biopsy, we're going to one of our urologic oncologist colleagues, either Bruce Bracken or Abhinav Sadhana or Krish Gaitande over at UC. But we do have the MRIs, yes. So, it's good for either monitoring active surveillance of prostate cancer, so that's key.
Right.
You have prostate cancer, we're watching, we're monitoring, or, and this may not pertain to any of you here in this room, but if you've had a negative prostate biopsy in the past, but your PSA keeps rising, or you have a new nodule, or something on prostate exam. So the idea there is, let's look for highly suspicious areas on an MRI, and let's target our biopsies to make sure we don't miss those areas. We still do a 12-core biopsy, but we make sure we take 3 or 4 biopsies in those high-risk areas to really make sure that we're not missing them.
So is an MRI always done before biopsy?
Not always. The 2 main indications are either for the active surveillance biopsy about a year later, 6 months to a year later per protocols, or someone who has had a negative biopsy, but the PSA continues to rise. Every now and then we'll do it. We have to fight with the insurance companies just a little bit, but most of the time we can get this done. If someone is either not necessarily a surgical candidate, but also not a perfect active surveillance candidate, and so we know that, let's say they have Gleason 7 prostate cancer in 3 cores, but they've had a couple heart attacks, a stroke, they're on oxygen, and we're just keeping an eye on it to make sure. But at this point in time, we are not at a point where we can say that multi-parametric MRI rules out prostate cancer. Okay, that's a key point. We're probably heading in that direction where the negative predictive value, meaning you get it and you can say based on the test that you don't have prostate cancer. It's probably going to be pretty good, but we're not there yet. And so sometimes I'll have patients in the office that say, hey, I've got an elevated PSA, can I get an MRI first, and then we'll do the biopsy. The decision to get the biopsy is based on exam, family history, PSA, and PSA kinetics. What's the PSA doing over time? I had a guy 3 weeks ago that was like, he saw another urologist in town. He had a PSA of 17. It went from, we didn't have any prior ones from 2 years prior, but he had a 13, a 15, and a 17. And he came to me for a second opinion and said, I want this MRI to see if I need a biopsy or not. He had never had a biopsy before. Okay, PSA of 17. I did an exam on him. He had a slightly large gland, and I told him, look, I'm gonna be very honest with you. I can get you this MRI. Not a problem. Not a problem. I can get it. but my recommendation is still the same. You have a PSA of 17. I feel a slight abnormality on your prostate. This MRI is not necessarily giving me any more information in terms of whether we need to do a biopsy versus not. I told him we can do an MRI fusion biopsy, but that would be done at UC at this present time, but usually that's indicated for patients that have had either active surveillance or negative prior biopsy. Okay.
On that same subject, I mean, first of all, thank you for coming.
Yeah, no problem.
What they tell us is that one of the main benefits of MRI is that it sees the entire gland, while your core biopsy will not. I mean, will not go all the way up to the base. And that there's quite statistically quite a high probability that a random biopsy will miss prostate cancer.
Correct. There is. There is.
So how can you not recommend an MRI is what I'm asking.
Yeah, so we can recommend it. If you look at, oftentimes when we do cost benefit analysis of it, and I'm not talking me doing cost benefit, I'm talking about insurance companies, National Cancer Institute, NCCN, the first time biopsy, at least right now, we're picking up enough prostate cancers doing just a sextant biopsy. Okay, now that data is coming out. You're hitting on a very important point. If you go to UC, for instance, and I'm just using this as an example just because I train there, they are enrolling patients in studies right now to see whether there's any added benefit of immediately getting an MRI before your prostate biopsy for the first biopsy. Okay.
Doesn't make any sense at all.
Yeah.
I mean, you get the scarring from the biopsy, which makes
but I guess the way that they see it, and again, I can't give you any hard data on this, but the way that they see it is, if I did your biopsy, you had a Gleason, or let's say you had a PSA of 7 and a nodule on your prostate, or no nodule on your prostate, and I'm doing a sextant, and you had a relatively small prostate. We're not talking 150 gram prostate, you have 30, 35 gram prostate. The idea there is that if you're getting different zones of the prostate and you're doing it in a very template fashion, you're going to pick up clinically significant prostate cancers, but there's going to be selection bias when you do the MRI. Okay, when you're doing an MRI biopsy, you're taking multiple biopsies of an abnormal area, right? But you may, let's say, I see a little lesion there and I take 5 biopsies from that abnormal area and it shows 5 of those are Gleason 6, but the rest are no prostate cancer. Now I've skewed this to thinking that you have more clinically significant prostate cancer, right? Because you have 5 out of 17 cores that are positive, but they're all Gleason 6, and all 5 of those biopsies are right next to each other. So I'm actually selecting for higher volume disease, even though you may not have higher volume disease. Whereas when you're doing a sextant biopsy, and I'm not saying that necessarily a sextant biopsy is better. By all means, I think an MRI biopsy is better. The question is it cost effective, and are you going to pick up more prostate cancers? We want to pick up prostate cancers, but we want to pick up clinically significant prostate cancers. If you're a 70-year-old gentleman and or let's say you're 70, 75 years old and we're doing your PSA and prostate exam suggesting you need a biopsy, okay? The last thing I want to do is diagnose Gleason 6 in 1 out of 12 cores with you, because that's not going to cause you any issues probably for the remainder of your life. What I want to catch is the guy who has 3 out of 12, or 5 out of 12, or 10 out of 12 Gleason 7s. 3 plus 4 or 4 plus 3.
Yeah.
I want to catch the prostate cancers where, by putting you through the biopsy and discussing with you what the treatment options are, we elect a treatment option that is actually going to affect your prostate cancer. Otherwise, I could get any 65-year-old guy with a PSA of 4. I could say let's everybody get an MRI, and I may find prostate cancer, but that's the controversy in prostate cancer screening in the first place. And we know that there's some men that are being overdiagnosed with prostate cancer. You know, if you think about the incidence of prostate cancer, interestingly, you know, about in 2018 there were 164,000, 165,000 new cases of prostate cancer, which accounted for 10% of total cancers. In total cancers. The prevalence in 2015 was 3.1 million men who had prostate cancer. So not that particular year, but all men with prostate cancer had 3.1 million. So when if the lifetime risk of having prostate cancer is about 11%, this is all data that's in the NCI, NIH gleans this data, all that. You know, we have noticed since 2005 that the incidence, believe it or not, has actually gone down about 2 to 3% a year. You know, we've actually seen that the incidence is going down. And my hope is that the incidence is going down because we're biopsying the right patients in the right way, right? We're not just saying, oh, your PSA jumped. You know, I'm far more concerned about the guy who goes from a PSA of 1 to 2 to 4 than I am a guy who's 3.9, 4, 4.1, 4.2. He may have prostate cancer, but the kinetics of that prostate cancer are probably that it's low risk, low grade prostate cancer. Whereas the guy who goes from 1 to 2 to 4 to 8, that's the one that we want to make sure we're not missing. And so, you know, you're hitting the nail on the head with regards to, yes, you're absolutely correct. The MRI is a very useful thing, but it's got to be used in the right way. It's got to be used for the right reasons, and it's got to get the right information. You know.
On that, on that subject,
Yeah.
there are now these non-invasive tests somewhere between PSA and biopsy or MRI,
Yes.
like PCA3, 4K.
Yeah.
Have you guys had any experience with those?
Yes. So it's almost like there's 3 or 4 different tests, and usually you kind of pick the one that gives you the most meaningful information. I don't have as much experience in PSMA but Pro PSA and stuff like that I do. So Pro PSA is a part of the 4K test. Okay, the 4K test I use for 2 reasons, and usually 2 reasons only. One is to convince a guy you need to have a biopsy, and the other is to convince a guy you should not have a biopsy. Okay. If I have a gentleman who's, sorry, this is kind of reverbing a little bit. If I have a gentleman who's 57 that has an elevated PSA and he's like, I do not want a biopsy. No, don't even talk about it. I tell that guy, okay, let's get your 4K score test. Okay, let's see what that risk of finding. Are all of y'all familiar with the 4K test?
No.
Okay, so the 4K score test is a blood test, much like PSA, but it gives you one really important piece of information. Not what are the chances that you have prostate cancer, but what are the chances you have clinically significant prostate cancer, like a Gleason pattern of a 4 or 5. Okay, so that's the goal. What are the chances you're going to have intermediate or high risk prostate cancer? So for the guy who's 57, if he's like, you may have a PSA of 5.2, 5.3, right? And normal for someone in their 50s should be maybe about 3.5. And he's like, I don't want a prostate biopsy. I say, okay, let's check this 4K score test. If it comes back low, we can, it's not a be-all end-all, but at least it's a prognosticator, and so I can talk to him about saying, okay, let's check it in 6 months, knowing that at some point it's going to get to a level where we need to do the biopsy, provided that score is low. And I think their threshold for low is like 7.5%. So the idea there is if the score is less than 7.5, it means you have whatever that percentage is, chance of having high risk prostate cancer, or intermediate or high risk prostate cancer. So, yeah.
Doctor, does that 4K have any other kind of a name to it? You've heard of it?
It's by a company called Opco, OPKO, but it's just called 4K score.
Do you use a urine test too?
No, it's a blood test.
No, the other test?
There are some urine tests.
Yeah. PAC3.
PCA3.
PCA.
I haven't used that as much as I think that the 4K score is probably a little bit better.
Better.
I think it's more validated. Plus it gives you it not only gives you the PSA,
Right.
but it gives you a couple of those other factors, the free PSA, the pre-PSA, et cetera.
Yeah, the urine
So-
just shows a few factors.
Yeah, so just to finish that point up is the 57-year-old guy, he has a low score, I say, okay, we can keep an eye on it. He has a high score, I say, you need that biopsy. Similarly, if a guy who's 75 or 80 years old is like, doc, I need this biopsy, I gotta have this biopsy, and I'm like, why did you even check your PSA? You know, I always have a guy who comes in who's like 80 years, we always get referred patients who are like 82 that has a PSA of like 5. And I'm sitting here like, it is abnormal, but you're 80 or 82. Should I put you through the biopsy and this and that? Because even if you do have Gleason 7, I mean, I can't prove to anybody that I can get them to 92, right? You just can't, right? So I tell that guy, hey, let's get the 4K score test. And there's a little more leeway there. You know, I don't really care about the 7.5 cutoff, but at least I can put it in numbers to him. So let's say his score was 20%. I say, sir, you're 82 years old. If I put 4 other of your counterparts with the exact same situation as you right next to you, one of you is going to have intermediate or high-risk prostate cancer. You all may have prostate cancer, but clinically significant prostate cancer. And so by doing that, I tell this guy, and again, it's a piece of the puzzle. I'm not telling him don't do it. I just say, hey, look, here's a little bit more information. 20% chance of having intermediate or high-risk prostate cancer. I would consider that low at your age. Do you still want to proceed with the prostate biopsy?
Can I just follow up on
Yeah.
that? So 4K
Yeah.
is standard of care, will it be covered by?
It's in our guide. It's in our NCCN guidelines. We have a mutual understanding with the manufacturer that I think out-of-pocket cost for that, we don't order it everybody. Because if they bill it through insurance, it could be anywhere from free to $1,000. So we have a understanding with them, and I've talked to them that I think out-of-pocket, if it's just not even through insurance, is no more than I think $399 or something, $399. But again, don't hold me on that. I can check on that for you guys. But again, this isn't a test that we're ordering on everybody, and you have to meet certain things. Like you can't do a digital rectal exam, like right before you run the test. You have to have, you can't have had a prostate biopsy before, or at least in the last 6 months. So it's a very particular sort of thing before we send that off. But that is a blood test, and we actually draw that blood in the office. So, sorry.
The PHI test, can you talk about that?
PHI, I haven't used all that much. It's an index. It's an index which I believe is looking at your pro PSA. So you're looking at PSA, free PSA, pro PSA, and it's basically doing something very similar, very similar to the 4K score test to figure out whether you're at a higher risk of clinically significant prostate cancer. I have not used that test all that much. I remember talking to the reps when I was down in Georgia about it, and from a sort of, it's one of those things where if there's 10 tests, you kind of pick the 1 or 2 that seem to work well, and not necessarily work well, but that are actually going to affect your clinical decisions. I know that there are a lot of urologists that do swear by that and use it very well. I just don't have enough information to give you kind of my real world experience with that. But again, that is another test that is very useful pre-biopsy. And then there's also these tests that are post-biopsy that you can do to further prognosticate you, like the Decipher test. You may have heard of that. Oncotype DX, Polaris, those sorts of tests. So there's a lot of genetics these days in terms of prostate cancer.
Can you talk about those later, the
Yes,
biopsy?
absolutely, I will. Yes, sir.